Hi guys, this is a final video from the rheumatology series. So today we will be learning about periarticular disorder. Now if you're someone who is preparing for NEET SS, this is not a very high yield topic. I don't say that you should be neglecting the topic, but this is not a very high yield topic. But if you're someone who is preparing for INISS, I'm not talking about someone who is preparing for the rheumatology INISS. Even if you're preparing for any other specialties concerned with general medicine, this is an important topic. They have asked innumerable questions from the topic, right? Okay, so we will be focusing on learning about periarticular disorders. Now, when we talk about periarticular disorders, there are other terminologies that come to our mind, like for example, regional pain syndromes, then soft tissue rheumatism, right? So soft tissue rheumatism, periarticular disorders, or regional pain syndromes are the terminologies which are often used interchangeably. Do they mean the one and same? To some extent, yes. Okay, so let us get the perspective right. Now, what are the disorders that we generally consider or discuss under rheumatological disorders? The disorders where the joints are affected. Then obviously we call it as arthritis, right? Arthritic disorders, like classical example being rheumatoid arthritis. Then the disorders where the connective tissues are affected, right? That is the second set of disorders. Then the third set of disorders where the blood vessels are affected, what we call as vasculitic conditions, right? Then the fourth set of disorders where the muscles are affected, autoimmune process and muscles affected, that we have already addressed. The fifth set of disorders is what we are talking today, that is periarticular disorders or soft tissue rheumatism. So when we talk about soft tissue rheumatism, mainly the tissues in and around the joint which are not integral part of the joint, but they are supportive structures. Soft tissue supportive structures of the joint are affected, right? So what are the important structures? The important structures are bursae, right? So bursae being affected, tendons. When tendons are inflamed, being part and parcel of the joint process, also joint disease also, then like that is a separate thing. But when only tendons are affected, the joints are unaffected, yes, we can discuss those conditions under soft tissue rheumatism, right? Tendons are affected. Enthesitis, well, yes, that can also be considered as a soft tissue rheumatism if it is an isolated finding. But most of the cases, enthesitis is part and parcel of the autoimmune process where the joints are also affected, right? Tendons, bursae, and your joint capsules. Joint capsules. If these are affected, we can discuss these under soft tissue rheumatism. Now, the conditions which can be called as soft tissue rheumatism can be broadly divided into regional pain syndromes where there is localized involvement or generalized pain syndromes, right? So when we talk about generalized pain syndrome, the first thing that comes to our mind is fibromyalgia. This we have already addressed in a separate video, right? Now today our focus will be on regional pain syndrome. So let us go through these regional pain syndromes one by one, taking one region at a time. So the first regional pain syndrome we are discussing is shoulder joint, right? So shoulder joint is our first area. Okay. Now before we discuss these entities, I have to also make it clear that when we talk about these regional pain syndromes or periarticular disorders, basically we're talking about injury caused to these structures because of repetitive trauma. There is no autoimmunity involved, there are no antibodies involved here, there is no autoinflammatory process involved here, and as such, degeneration is also not a major contributor. Yeah, if you're talking about rotator cuff tear in an elderly person, maybe degeneration is a contributor, but otherwise, most of these periarticular disorders are due to repetitive trauma. This is very, very important, right? This is very important because when we talk about treatment of these conditions, the first thing is to avoid repetitive trauma, right? That will be our first important step in management of these patients. And the second thing is, because these patients develop these regional pain syndromes because of repetitive trauma, right? They may not land up in an orthopedician's clinic, right? For example, if I'm someone who fell with my outstretched hand and developed a neck of humerus fracture or a dislocation of the shoulder, then I will land up in an orthopedician clinic. But if my shoulder joint is paining for many days, most likely I will land up in my GP's clinic, or most likely I will land up in my physician's clinic, right? So that's why we should be very much aware about these regional pain syndromes. Okay, so the first regional pain syndrome we're talking about is the shoulder joint. Now, in the shoulder joint, there are three entities we need to know. One is frozen shoulder, the second one is impingement syndrome, and the third one is rotator cuff tear, right? Now, before we discuss these conditions, we have to understand a little bit about the anatomy of shoulder joint. Only 2 or 3 important points I want you to note. Okay, point number 1 is we have this rotator cuff and we are discussing about rotator cuff tear. So we should know what are the components of this rotator cuff, right? That's the first thing we have to address. Now the component of rotator cuff is formed by tendons coming from the rotator cuff muscles, right? So what are the components? The components of this include are 4 muscles. There are 4 muscles included. One is supraspinatus, supraspinatus. The second one is infraspinatus. That's the second muscle. Then the third one is our subscapularis. Subscapularis is the third one. Okay, and the fourth one is teres minor, right? Teres minor. These are the four muscles which are forming the rotator cuff, right? This is the first point I wanted to know. MCQs have been asked in the INISS, which of the following is or is not a component of the rotator cuff, right? So knowing this is important for us, and we can easily remember this with a mnemonic. We can remember this with a mnemonic SIST, S-I-S-T, right? The mnemonic is your minor sister rotates your shoulder, right? The mnemonic is your minor sister rotates your shoulder. So the components are SIST, your SIST rotates your shoulder, right? Your minor sister rotates your shoulder. So what are the components? S here stands for supraspinatus, I here stands for infraspinatus, another S stands for subcapularis, and the T here stands for teres minor, your minor system, right? And these are the components of rotator cuff. Up. That's the first point we have to understand from the anatomy of shoulder joint. The second point I want you to notice the bursae, right? Every time you talk about a joint structure, for the soft tissue rheumatism conditions or for periarticular disorder, bursa is where we have to pay attention, right? So here you can appreciate one bursa. Can you see this bursa? What is this bursa called as? This bursa is called as subacromial or subacromial bursa. Subacromial bursa. Okay. Now, if there is an MCQ asking you what is the most commonly affected bursa or most common bursitis, it is subacromial bursitis only, right? So remember this point. This is the most commonly affected bursa. Okay. Why this is particularly important? Look at the location of this bursa. It is present just beneath the acromial process of the clavicle, right? So just beneath the acromial process of the clavicle, and under this bursa you can notice that there is a tendon. Can you notice this tendon? This tendon is coming from which muscle? Look at this. This is a muscle and its tendon is passing just beneath this subacromial bursa to get inserted into greater tuberosity of the humerus. So what is the tendon we're talking about? We're talking about the supraspinatus tendon, right? So if there is subacromial bursitis, what is going to happen? The bursa gets tender, swollen, inflamed, and it can cause compression or impingement on the supraspinatus tendon, right? So this is one point I want you to note, right? Clear? Now let us go and discuss the important regional pain syndromes with respect to shoulder. The first thing we are talking about is frozen shoulder, because that is the most commonly encountered regional pain syndrome in a physician's clinic, right? So what we know about frozen shoulder, we know that this is typically seen in patients with diabetes mellitus, right? So diabetes mellitus is an important risk factor and female gender is an important risk factor. I don't know, for some weird reason, whatever patients of frozen shoulder I have seen, most of them were males. I at least don't remember any female patient having seen, but books mention females as the important risk factor, right? So a female diabetic, like when we talk about diabetic, mostly they will be 40 plus by the time they present, right? 40 plus. So any diabetic 40 plus, particularly female, presenting with shoulder pain and restricted movement, the first thing that should come to our mind is frozen shoulder, right? So why do we call it as frozen shoulder? We call it as frozen shoulder because there is restriction of movement and there is pain, right? Restriction of movement. Now, why there is a restriction of movement? This restriction of movement is because of adhesive capsulitis. Adhesive capsulitis. Why there is adhesive capsulitis? We don't know. We know that diabetes is a risk factor. We know female gender is a risk factor. We know age is a risk factor. But beyond that, we don't have established link between diabetes mellitus and adhesive capsulitis. But the joint capsule gets inflamed multiple times and develops adhesions, and because the adhesions, there is restriction of movement, right? Now, MCQ wise, they might ask you what is the movement that is first restricted. There is generally, like as the disease progresses, there is generally global restriction of movement, but MCQ wise, they might ask you what is the first movement that is restricted, right? The first movement that is restricted is usually, so remember this point, first movement to get restricted is usually external rotation of the shoulder joint, right? External rotation of the shoulder joint followed by internal rotation followed by your abduction adduction, right? So these patients have a difficulty in externally rotating their shoulder joint, right? They will not be able to externally rotate their shoulder joint. If you remember going through ward rounds and having seen your physiotherapist administering physiotherapy to your diabetes patients who have already developed frozen shoulder and you have hospitalized them because you wanted a good glycemic control or they have other complications, then you would have noticed them doing this external rotation, internal rotation exercises, right? Okay, because that is the most commonly restricted movement. So this is how the patients will present, right? Diabetic patient presenting with shoulder joint pain and restricted movement. Eventually, globally, to start with external rotation, that is the most commonly affected. You will think of the diagnosis of frozen shoulder. Now, how do we diagnose? Diagnosis is mostly clinical. If you do an X-ray of the joint, it is going to be normal because the joint surfaces are not affected. It is a capsule that is developing adhesion and X-ray fails to pick it up. But if you do an MRI, it might show adhesive capsulitis. Do we need an MRI? Definitely no. The clinical diagnosis suffices in most cases, right? You have a diabetes, female or male, 40 plus, presenting with shoulder pain, restricted movements. Diagnosis for all practical purpose is frozen shoulder, right? How do we treat these patients? The treatment of frozen shoulder is in the form of, you can definitely use NSAIDs to relieve their pain. Then you can give a good physiotherapy and good glycemic control, right? Good glycemic control, NSAIDs and good physiotherapy. In some patients where this is not adequate, patients are not being helped with these measures, you can think of surgical adhesionolysis, right? So that is the approach for frozen shoulder. Okay, so the next condition we're talking about is impingement syndrome. Right? So what is impingement syndrome? Impingement syndrome is a condition where we see patients presenting with pain in the shoulder joint because of the impingement of supraspinatus tendon. Supraspinatus tendon. Okay. Now we have already seen this image and we have seen this tendon. It is just beneath the subacromial bursa, right? Now, what is the important movement that supraspinatus muscle does? The movement that supraspinatus muscle does is your abduction, right? Your abduction. Now, whenever there is subacromial bursitis, some other causes are also there for the impingement syndrome, but most commonly it is subacromial bursitis. So, whenever there is subacromial bursitis, when the arm is abducted, right, the tendon gets impinged between acromial process and the head of the shoulder because the bursa is occupying too much of space. This impingement causes pain. What is the pain triggering movement? The triggering movement is abduction, right? Typically, the pain occurs in the mid-range of the movement, right? Mid-range of the movement, 60 to 120 degree. So when the movement is at 60 to 120 degrees, patient experiences pain. And this is where there is a restriction to the movement because at this point of time, between your acromion process and the head of the humerus, your supraspinatus tendon is getting impinged, right? So this is what we call as impingement syndrome. Okay. So once we have suspected impingement syndrome, how do we diagnose it? We diagnose it by using a test called as Neer's test. Clinical diagnosis, the test is called as Neer's test. There are two tests, in fact, Neer's test and Hawkin-Kennedy test. Hawkin-Kennedy test. Okay, Neer's test is very simple to do, and this is what most of us do in our OPD. Right? So what do we do in Neer's test? What is the abnormality here? When we try to abduct the arm, the supraspinatus tendon is getting impinged. So we try to provoke this. And so what can we do? Hold the patient's shoulder in internal rotation, right? Internal rotation, and then try to abduct it. When we try to abduct it, it precipitates the pain, particularly when the range of movement is between 60 to 120 degree. Here, mid-range of movement, it precipitates pain, right? So that confirms that there is impingement syndrome, right? Okay, so how do we treat patients with impingement syndrome? The treatment of patients with impingement syndrome is mainly with NSAIDs, right? NSAIDs and sometimes local steroid injections. Local steroid injections. Okay. In worst case scenario, you might have to consider surgery. Like surgery is beyond the scope of a medicine person. Like we end up just referring these patients to orthopedician and probably they will look after, right? So this is our impingement syndrome. Now the third entity we are talking about is rotator cuff injury. So rotator cuff tear is what we are talking about. Now when we talk about rotator cuff tear, you have to understand that there are four muscles. They might ask you what is the most commonly affected tendon, the tendon that gets ruptured in rotator cuff tear, right? So the most commonly affected tendon is what? The most commonly affected tendon is again supraspinatus, right? It is supraspinatus. That is the most commonly affected. It's like supraspinatus is like a bechara muscle, right? You talk about impingement syndrome, it is the one which is getting affected. You talk about rotator cuff tear, it is the one which is most commonly getting affected, right? Other tendons can also be affected, but most commonly affected is supraspinatus, right? Okay. So tear in young people is usually because of trauma. So in young, it is because of trauma, but in elderly, it can be because of degenerative changes. In elderly, it is because of degenerative changes. Okay, is that clear? Okay. Now, how do we diagnose these patients? Well, we can examine for all these movements, all the rotational movements of the joint, but most commonly because supraspinatus is affected, we try to demonstrate that first, right? So supraspinatus job is abduction, and here what we are trying to do is we are trying to do a test called as MT-CAN test, right? So where do we use MT-CAN test? We use MT-CAN test for the diagnosis of rotator cuff tear. We call it as MT-CAN test. Okay, what is MT-CAN test? Now, if I give you a can, right, maybe a beer can or maybe a can of oil or something, and ask you to empty it, what do? You hold the can like this or like this, and then you try to empty it, right? Or if you're holding it like this, you're trying to empty it. Now, when we do this movement, right, that triggers the pain. This is what we call as MT-CAN test. So we ask the patient to stretch their hand out like this, right, and then we ask them to internally rotate the shoulder, right? Internally rotate the shoulder. Okay, we ask them to internally rotate the shoulder, and this precipitates the pain. When we are doing this, we try to apply the pressure down, like examiner applies the pressure down, and that precipitates the pain. This is what we call as MT-CAN test, and that is suggestive of rotator cuff tear, right? So MCQ wise, they might ask this. MT-CAN test is used for which? That is for integrity of supraspinatus tendon and for suspected case of rotator cuff tear, right? Okay, so now let us run through some of the images. So what is being documented here or what is being demonstrated here? It is like an exercise for treatment of frozen shoulder, right? So the patient is holding on to a door and trying to rotate the body, because the rotation of the shoulder joint is what is restricted in patients with the frozen shoulder, and if we let it get restricted like that, the adhesions will become much more profound and patient will have much more difficulty in releasing the adhesions, right? Okay, those patients who have very stiff joint, maybe we can do this exercise or release adhesional lysis under anesthesia, right? Okay, now what is being demonstrated here? The Neers test, right? The Neers test is the one that is being demonstrated here. So patient is like, the examiner is stabilizing the patient's scapula, right? And then she is abducting the arm. With the internal rotated arm is being abducted, and if that precipitates the shoulder joint pain, that says the Neers test is positive, right? So where do we use the Neers test? We use the Neers test for diagnosis of impingement syndrome, right? Impingement syndrome. So here we are talking about impingement syndrome. The alternative test was Hawkins test, Hawkins-Kennedy test. Hawkins-Kennedy test. The difference between the Neers test and Hawkins-Kennedy test is the same maneuver, but we are trying to do with elbow flexed. Right? The same maneuver we are trying to do with elbow flexed. Clear? Okay. Now, what is being demonstrated here is MT-CAN test. So, for what we do that? We do that for a rotator cuff injury, mainly when we are suspecting supraspinatus tendon being affected, right? Supraspinatus tendon being affected. So, what are we doing here? The examiner is first asking the patient to have their arms outstretched, then internally rotate like as if you are emptying a can, and then he is applying downwards pressure. Now, if that is triggering the pain, that is suggestive of rotator cuff injury, right? MT-CAN test is for rotator cuff injury. Clear? Okay, so that completes our shoulder joint. Now coming to the elbow joint related regional pain syndromes. So elbow joint, there are two things to talk about. One is bursitis and tendinitis. So first let me address bursitis. What is the important bursa around elbow joint? We are talking about olecranon bursa, right? So olecranon bursitis is a common thing to see. Olecranon bursitis is very common. Okay, and we call this as student's elbow. We call it as student's elbow. Why is it called a student's elbow? Like, you are a student who is in a classroom trying to listen to a boring lecture. Most likely you are sitting like this, right? Or in fact, you might have noticed that most often my posture is like this. And in fact, I have some evidence of olecranon bursitis right now, because when we are sitting in this posture, we are resting our elbows on our olecranon bursa. You are in a library reading, or you are in a classroom trying to listen, or like me when talking about the diseases, I am resting my elbow on the olecranon bursa. So this repetitive trauma to the olecranon bursa can trigger olecranon bursitis, and students are the ones which are most commonly affected. That's why we call it as students elbow, right? How do we treat? NSAIDs and avoidance of repetitive trauma. That's the most important thing, because repetitive trauma is responsible for most of these manifestations. Avoiding the repetitive trauma is the most important thing here, right? So olecranon bursitis is what we call as student elbow, and this has been asked 2 or 3 times in INISS. Student elbow is due to injury to, they had mentioned bursa, they had mentioned tendinitis like medial epicondylitis or lateral epicondylitis as the answer. So when we talk about tendinitis, right, so we know that in case of elbow, there is common flexor origin of tendons, there is common extensor origin of tendons, and they can be affected, right? So we have this medial epicondyle from where there is common flexor origin, right? From there is common flexor origin of the flexors of the wrist, right? And then we have this lateral epicondyle, and from the lateral epicondyle we have a common extensor origin. Okay, so when there is common flexor tendinitis, we call it as what? When there is common flexor tendinitis, we call it as golfer's elbow, right? Golfer's elbow, because when you're hitting the golf, you're mostly causing the forced flexion of your wrist during this movement. So your medial epicondyle, common flexor tendons are more likely to be injured. Though golfers often suffer from the tennis elbow also, which is the lateral epicondyle involvement. So lateral epicondyle involvement is what we call as tennis elbow, right? We call it as tennis elbow. So these terminologies like medial epicondylitis or common flexor tendinitis is what is referred as golfer's elbow, and the terminology is what we generally address as lateral epicondylitis or common extensor tendinitis is what is called as tennis elbow, right? So the most common profession that suffers from tennis elbow is not the tennis players, it is indeed cricketers, right? Cricketers followed by tennis people. So in both these cases, there is repetitive trauma responsible for this manifestation, right? Now, how do we examine these patients present with pain affecting either medial epicondyle or lateral epicondyle? Now we have to confirm this, right? So again, confirmation has to be through provocation test. So the test is known as Cosen's test, right? There are two types of Cosen's test: the conventional Cosen's test and your reverse or inverse Cosen's test. Reverse or inverse Cosen's test. Okay. Now, what is the Cosen's test? So what we try to do in Cosen's test is we ask the patient to have her outstretched hand, right? And then we ask them to extend the wrist against examiner's resistance, right? Examiner is offering the resistance and this is patient's hand. He is trying to extend the wrist. So in doing that, his extensor tendons are under pressure, and if there is lateral epicondylitis, patients will experience pain, right? So Cosen's test is used for diagnosis of which condition? For tennis elbow. Cosen's test is for tennis elbow. Now, in case for reverse Cosen's test, we are doing the exact opposite to that. Patient is having this upper extremity outstretched and we are asking him to flex the wrist against resistance. So when he is flexing the wrist against resistance, his medial epicondyle common flexor tendon is under pressure and he experiences pain there if there is medial epicondylitis or if there is golfer's elbow, right? So our reverse Cosen's test is for golfer's elbow. It's for golfer's elbow, and our Cosen's test is for tennis elbow, right? Clear? Okay. Now, how do we treat these patients? Rest, avoiding repetitive trauma is very, very important. So if the profession that is putting the patient at risk of developing repetitive trauma, then patient might need to take some break from the professional sports activity. That's first thing. NSAIDs can be helpful to relieve the pain. And the third thing is we offer something called as counter force braces. Counter force braces. So what are these counter force braces? Like these are braces which kind of offload the pressure on the medial or lateral epicondyle. Like they are inserted proximal to here. Like when there is a brace inserted here, when you're trying to do the movements, right, the pressure on the medial or lateral epicondyle is offset by this brace. That is what we call as counter force braces. So counter force braces can be used for treatment of your golfer's elbow and tennis elbow, right? Clear? Apart from that, yes, local injection of steroids is also practiced, right? That can also be considered. So this is about the elbow conditions. Now, the next thing we are talking about is, so this is the image where you can clearly see the patients being examined for Cosen's test, right? Extension is what is being done here. So it is a Cosen's test. So if they are examining for flexion, then it is called as inverse or reverse Cosen's test. Okay. Now coming to wrist. What are the soft tissue rheumatic conditions that are important from the wrist? The first one is decurvens tenosynovitis, which is something very often we encounter in our clinical practice. And then Dupuytren's contracture. Dupuytren's contracture is something that we know from our undergraduate days, right? So there is a palmar fascia which has become thickened, right? Thickened fibrotic palmar fascia is responsible for Dupuytren's contracture. Only important thing to notice, they might often ask which finger tendons are most commonly affected, right? So it is the ring finger that is most commonly affected. So, okay. Beyond that, I don't think I need to talk much about it. So let us go back to this de Quervain's tenosynovitis. So in de Quervain's tenosynovitis, patients usually present with pain over radial styloid process, right? This pain is because of tendinitis. Now, what are the tendons passing over the radial styloid process? Patients present with pain over radial styloid process, right? So what are the tendons passing over this structure? There are two tendons we need to remember. One is the tendon which is known as abductor pollicis longus, APL, abductor pollicis longus. The second one is extensor pollicis brevis, EPB. Abductor pollicis longus and extensor pollicis brevis. These are the two tendons which will pass over your radial styloid process. Now, repetitive trauma at this point can trigger the pain, right? So the pain will be just over the radial styloid process, right? Again, obviously, repetitive trauma is responsible for the tendon injury. Now, how do we confirm this test? When someone presents with the pain over the radial styloid process, how do we confirm? The confirmation is with a test called as Finkelstein test, right? What we call it as? The test is called as Finkelstein test. Finkelstein or Finkelstein test. So what we try to do here, we ask the patient to close his thumb like this and then make a fist, right? And after making the fist, we ask them to move the wrist towards the ulnar side, right? So when he is moving the wrist towards the ulnar side, these tendons which are passing over the radial styloid process are getting stretched, and that triggers the pain. This is what we call as Finkelstein test, right? So Finkelstein test is for diagnosis of what? It is for diagnosis of de Quervain's tenosynovitis, right? De Quervain's tenosynovitis, right? That is one wrist condition that we're talking about. Then the second wrist condition we have already spoken about is Dupuytren's contracture. The third thing we should also know is about something called as diabetic cheiroarthropathy. Diabetic cheiroarthropathy. Okay, what is diabetic cheiroarthropathy? Here, patients usually present with fixed flexion deformity of the fingers. Why am I talking about it? I'm talking about it because we have already spoken about Dupuytren's contracture, where patients are presenting with fixed flexion of ring finger and eventually maybe other fingers, right? So in diabetic cheiroarthropathy also patients can present with fixed flexion deformity, right? Okay, so this fixed flexion deformity of diabetic cheiroarthropathy leads to something called as prayer sign, and this prayer sign has been asked as an MCQ in the last NEET assess, right? That asked this prayer sign, right? So what is prayer sign? Look at this image. What are you noticing here? Because the fingers have gone into fixed flexion, right? Fixed flexion, they are unable to oppose the arm, oppose the hands like this, right? They're not able to make this complete proper namaskara. It is in this form, right? This is what is called as prayer sign. So MCQ that was in the last NEET assess was prayer sign is seen in which of the following condition, right? So prayer sign is seen in diabetic cheiroarthropathy. Diabetic cheiroarthropathy. Okay, so this is about the wrist regional pain syndromes, right? Now let us talk about the fingers. Now what are the finger regional pain syndromes we know? Yeah, this is a test where they're trying to demonstrate Finkelstein test, right? Finkelstein test. So they're trying to put pressure on this radial styloid process, the tendons passing through that, and that is triggering the pain, typical of de Quervain's tenosynovitis. De Quervain's tenosynovitis. Yeah, I forgot to mention one particular point. So whenever we hear this tenosynovitis, basically it is talking about a condition where there is synovial membrane, the synovial sheath that is overlying the tendon is getting inflamed, right? So this inflammation actually causes stenotic changes, right? So the synovial membrane starts becoming narrowed down, and that restricts the movement of the tendons, right? So here is the point where the tenosynovitis is getting affected, right? Okay. Now coming to finger, there are two important fingers we need to know. One is mallet finger, that is what most of the INISS questions were about, and the trigger finger, right? So what is trigger finger? Trigger finger is a condition where, like, to understand trigger finger, first we have to understand what we call as pulleys in the hand, right? So hand has the, like, if I'm just drawing this bones in the hand, this is our distal phalanx, right? This is our distal interphalangeal joint. This is our proximal interphalangeal joint, and this is our metacarpal. So this is our metacarpophalangeal joint. Now to keep these tendons, like on the flexor side of your fingers, we have these tendons called as flexor carpi profundus. Flexor digitorum profundus, which is getting inserted here, and then on the extensor side also there is a extensor tendon, right? So flexor tendon here, extensor tendon here. The extensor tendon is called as extensor carpi communis, right? Extensor carpi communis, which is getting inserted on your distal phalanx, right? Now this relative relaxation and contraction of these tendons causes the movements, right? Okay. Now to keep these tendons close to the bony surfaces and to act as pulleys, right? There are soft tissue bands or connective tissue bands. This is what we call as pulleys, right? We call these as pulleys. I think you can appreciate these pulleys from the images here, right? So there is one pulley here, right? There is one pulley on the metacarpophalangeal joint. There is another pulley on the proximal interphalangeal joint. Then you can see another pulley on the distal interphalangeal joint. So what these pulleys do, the tendons and the bones, they keep them close together and they facilitate these directed movements, right? So these are like bands of soft tissue or connective tissue which hold the tendon along with the bone. So these tendons move beneath these bands, right? Now if there is a constrictive changes in these pulleys, what will happen? There is an inflammatory change that will try to prevent the free movement of the tendon underneath it, right? So the tendon gets inflamed because of the restricted tendon movements. So this inflammation of the tendon often leads to formation of tendon nodules. So whenever there is flexion, these tendons are moving underneath these pulleys, right? Whenever there is flexion, and if there is pulley which is inflamed, then the tendon movement is affected, and because of the affected tendon movement, what do we see? The tendon forms a tendon nodule, inflamed nodule. Now this nodule, whenever we are doing a flexion, right, it facilitates flexion because you can see the tendon nodule here. The tendon nodule is present here, right? So it facilitates flexion. But when we try to do an extension, this tendon nodule has to pass beneath the nodule. This nodule has to pass beneath this stenotic pulley, right? So that will be difficult. So when patient needs to exert force to extend, so flexion is not affected, extension is which is affected, and because patient need to exert force, with the force suddenly there is giving away of the resistance and the finger opens up, like as if it is being triggered. That's why it is called as trigger finger, right? That's why it is called as trigger finger. Now MCQ wise they might ask you which pulley is affected in trigger finger, right? So these pulleys are usually numbered as A1 pulley, A2 pulley and A3 pulley, right? So A1 pulley is the one that is present over your metacarpophalangeal joint, and that is the most commonly affected, causing trigger finger, right? Okay, so this is about trigger finger. We can try to help these patients with NSAIDs, local injection of steroids, and sometimes surgical release of this. Most often patients will require surgical release of this pulley, right? This band of connective tissue that needs to be incised to release it so that the tendon can freely move, right? Once the tendon starts freely moving, whatever inflammatory nodule that has been formed, it will regress over time, right? Okay, so this is trigger finger. Now talking about the next condition, what we call as mallet finger. So what is mallet finger? We see patients presenting with a fixed flexion deformity at the level of distal interphalangeal joint. Why is this occurring? As we have seen in the previous image, you can appreciate in this image, there is a flexor digitorum profundus tendon inserting in the distal phalanx, and there is a extensor tendon inserting in the distal phalanx. So this is holding these the fingers and digits in structure. Now if there is tear involving the extensor tendon, what happens? The distal phalanx gets now in a fixed flexion position because the balancing force exerted by the extensor tendon is lost, right? So sometimes trauma can cause injury to this tendon, right? So often this tendon breaks away, even sometimes causing a small fracture of this distal phalanx, leading to fixed flexion deformity of the distal phalanx. This is what we call as mallet finger. You can appreciate in this image, right? This is what is called as mallet finger, right? In fact, in this image you can see a small fractured bone, right? So the tendon that was inserted here, the extensor tendon, is snatched away and it has caused a small fracture, and finally patient presented with mallet finger, right? Okay, so how do we treat these patients? we generally treat these patients with a what we call as mallet braces, right? We insert the finger in the mallet brace and let the patient recover from it, right? So that is about mallet finger. Now coming to the last soft tissue rheumatism that we are talking about, or the last regional pain syndrome that we are talking about, it is knee joint. Now knee joint, only two important points to note, right? Look at the knee joint here. Important points are with respect to bursae, right? So we can see two bursae here. One is your pre-patella bursa, right? We can see a pre-patella bursa here, and the second thing we see is your infrapatellar bursa, right? Infrapatellar bursa are basically two things. One is deep-seated or what we call a subtendinous, and then one more is subcutaneous, right? Usually when we talk about bursitis, mostly the subcutaneous are the ones which are most commonly affected, because those are the ones which are repeatedly subjected to repetitive trauma, right? Both these bursae can be affected because knee joint is like one of the most abused joint, right? So this involvement of subcutaneous prepatellar bursa is what we call as, what do we call it as? We call this as housemaid's knee. So this is also a point which has been asked as an MCQ multiple times. Housemaid's knee. Housemaid's knee is due to which bursitis? Housemaid's knee due to involvement of subcutaneous prepatellar bursa. Clear? Okay. Now the second thing is we are talking about infrapatellar bursa, mostly the subcutaneous infrapatellar bursa. So this involvement leads to something called as clergyman's knee. This leads to clergyman's knee. Okay. Now if you have a housemaid, right? So when she is cleaning the floor, just observe. You will notice, like, don't do that if you are a male and your housemaid is a female, but if you are a female and you have a female housemaid, just look at her when she is cleaning the floor. What you will notice is when she is cleaning the floor, her knees are rested on her prepatellar bursa. So because of that, prepatellar bursa becomes repeatedly traumatized and she develops something called as housemaid's knee or prepatellar bursitis. Okay. Now why do we call infrapatellar bursitis as clergyman's knee? So if you are from a Christian tradition and you observe your priest offering the prayers on their knees, then you will notice that they are resting their knees not on their prepatellar bursa, they are resting their knees on their infrapatellar bursa. So because of that, infrapatellar bursa becomes repeatedly traumatized and they develop infrapatellar bursitis. That is what we call as clergyman's knee, right? So olecranon bursitis causes student's elbow, then prepatellar bursitis causes housemaid's knee, and infrapatellar bursitis causes what we call as clergyman's knee. These three are important MCQ points. So with this, guys, we are winding up the session for today, and I wish you all the best for your preparation, particularly on the rheumatology side, and I'll be happy to share if there are any doubts from your side. Please communicate on the Prep Ladders Premium Facebook group.